three things today, that's good enough. Okay? So I'm serious. So how do you diagnose obstruction? How do you diagnose restriction? How do you diagnose some of the other conditions? So in fact, I tell my medical students, interns, fellows, there are only three questions when you read PFT. What are the three questions? Oh my God, she got two of them right. Yes. So is there obstruction? Is there restriction? What's the third thing we do? Pardon? Yes, severity comes with either obstruction or restriction. How is the gas transfer? Right. So those are the only three questions. So if you figure out these three questions, we have some qualifiers. Adding that, we have 5 patterns we can diagnose. Is it obstructive disease? Is it restrictive disease? Is it combined disease? Is it neuromuscular disease? Right? Or is it pulmonary vascular disease? So 3 questions, 5 patterns, easy. All right? So of course, we cannot develop into the test without talking about why we do this, right? So why do we do PFTs? Let's start from here. Why do we do PFTs? Lauren already said patients have, if the patients have dizziness. Can you think of anything, any other reason why we do PFTs? Textbooks will say what are the indications of PFTs? Diagnosis of asthma. Okay, so good. So dyspnea, that falls under the dyspnea category. Why else would we do PFT? To monitor effective treatment. Very good, very good. Why else would we do PFT? Very good. The time worsening or improving a condition. Good. Why else would we do PFT? I'll also tell you one more thing about me. There are 2 ways of teaching, right? You guys have heard about this. One is called the pedantic method. The second one is called the Socratic method. You guys heard about these before? Pedantic is, I put you in the class and I tell you 1, 2, 3, 4, 5, 6, 27, 30, you see. So data shows only 10% is retained. So the Socratic method of teaching is I ask you questions, I try to engage you. That's all I'm trying to do. So you are, I've done this with my medical students, scholars as well. You are in a position in your career where you can take intellectual risk. You can say anything. It is not wrong. Okay? You can, I'm not kidding. You're here to learn, so just go for it. So we do PFTs because we want to evaluate dyspnea. You want to know the difference between asthma and COPD. We're trying to evaluate the treatment that we're providing. We're trying to see side effects of medications. Why else do we do PFTs? So let's cut to the chase. So patients are having dyspnea. We want to see why they're having dyspnea. Cough is another place because cough comes in because of airway disorders, right? So patients having cough, oftentimes we will get PFTs. Patients have abnormal imaging. Does it have anything to do with airway disorders? Can we learn more about the patient's pathophysiology by doing PFTs? Sometimes we do PFT screening, right? Where do we do screening these days? We are asked to do screening for COPD, right? Especially if they have a history of smoking or a family history of COPD, even secondhand smoke exposure. We're doing screening PFTs. Monitoring pulmonary drug toxicity. Can any of you tell me one drug that can cause lung toxicity? Amiodarone. My goodness, awesome. I love it. So preoperative assessment. So the operation can either be a lung surgery, like a lobectomy or a pneumectomy or a resection. You see, hey, does this guy have enough lungs so we can take his lung out? So that is the preoperative assessment for lung resection. For non-pulmonary conditions, we want to know how fit these patients are, right? They have to go through anesthesia, they're breathing out these molecules, so that's preoperative assessment. And we're trying to assess for improvement or treatment effects of whatever. It could be asthma, it could be COPD, it could be interstitial lung disease, it could be amyloid toxicity as well. Good. So those are some of the reasons why we do that. So let's talk about causes of dyspnea, organ system wise. Obviously, a big player is lung disease, right? Lung disease can cause dyspnea. What else can cause dyspnea? Heart failure. So cardiovascular system. What else can cause dyspnea? Pregnancy, very good. So that's body, very good. Yeah, very good. Yeah. Well, remind me to talk about why pregnant ladies become dizzy. You may already know the answer. So good. Neuromuscular disease, right? Patients don't have the strength to move everything out. What else can cause dizzy? A broken rib, so chest wall disorders. Very good, very good. So obesity. So let's put that all together. These people have more to move, right? So their lungs are fine, their heart is fine, they have enough blood and everything, cardiovascular is good, but they have to do more work. That's that. Deconditioning. So somebody's been sitting idle, they have never climbed stairs. Now they have to stair one flight of stairs. Like me, I thought it was going to be 3 flights, it was actually 14 flights. One flight. I couldn't find the elevator. I said, they must be waiting. So I turned up. So deconditioning. Anemia. Don't forget anemia as a cause of dizziness, right? Because lungs are good, heart is working fine, even the cardiac output is fine, but there's not enough oxygen carrying capacity in the blood. So you have to keep that in mind. So anxiety, psychogenic. Why did I put that in a different color? Way the bottom is more fun. Mind is a big system, right?
You should rule out the others first before.
Very good, very good. So I told this to the fellows as well. The moment I start thinking my patient is crazy, my patient is lost, right? Seriously. But I'm going to miss so many other things that could have been wrong with my patient. So I put that way down, and I first visit, I don't even think of anxiety or psychogenic factors. So those are causes of dizzying organ system. Let's talk about some common causes of dizzying. We already talked about asthma, right? We already talked about COPD. And the types of COPD, we have chronic bronchitis, or we can have emphysema. There are differences. I'm sure you guys know that. And there is this other broad category called interstitial lung disease or pulmonary fibrosis. This is a scarring process that starts off in some parts of the lungs, and most of them are progressive. There are about 200 of them, 200 interstitial lung diseases. So that's that, and then there's pneumonia, right? Pneumonia can also cause obstructive breath, depending on the extent of involvement of the lung. Pleural effusion, outside of the lung, the bigger the pleural effusion, more the compressive atelectasis, less cardiac capacity, less all kind of volumes, patients will be dizzy. Pneumothorax, same pathophysiology, pulmonary embolism, right? So lungs are fine, bronchitis is fine, but the blood got blocked, blood flow got blocked, and then there's pulmonary embolism. So these are different colors. So and there's lung cancer as well, right? Lung cancer is a completely different color as well. I put that at the bottom. So dyspnea due to pulmonary causes can be due to airway disorders, pericardial disorders, pleural disorders, pulmonary vascular disorders as well. Why is lung cancer in a different color? And that color is not up there. Because lung cancer can cause dyspnea by so many mechanisms, right? Can somebody tell me how lung cancer can cause dyspnea? Block the airway obstruction, collapse. Lauren was going to say
It can change your red blood cell count, so it can cause
cancer, anemia, good. What else? Restrict movement, probably by atelectasis. Any other way lung cancer can restrict movement? Pleural effusion, right? Lung cancer can cause pleural effusion as well. And of course, any cancer is a predisposing factor for pulmonary embolism, so that's another mechanism as well. These patients can have hemoptysis, they spill blood from one part of the lung to the other, and that can also cause dyspnea as well. Good. So let's PFTs. Now we're going to talk about PFTs. So what are the components of PFTs? So we already alluded to the 3 things mainly we do. We do spirometry, trying to look at how air goes in and out, right? And by using the same, we measure some of the volumes, right? So lung volumes. Lung volumes also we measured separately. And then we look at gas transfer. How does oxygen and carbon dioxide go back and forth across an alveolar capillary membrane? Can any of you tell me how thick or thin the alveolar capillary membrane is? What is the alveolar capillary membrane? On one side is the capillaries, on the other side is the alveolus, right? This interface, how thick or how thin is it? It's crazy. Half a micron. Can you believe that? Half a micron thickness. It's amazing. It's amazing. Good. So we're gonna try to measure how the gas transfer across this as well. And what is MVV? Maximum voluntary ventilation. How much air can this person move in and out in a minute? So that can give you an assessment of a lot of things, right? How is the airflow? Is there airflow limitation? Is that limiting how much air these patients can move in and out? Right? Do they have the adequate neuromuscular strength to be able to move smoothly in and out? That can kind of give you an assessment. Good, good. So components of PFTs. So we're going to also talk about flow, volume, loop. So we're going to have, we're going to look at some pictorials where volume is going to be on x-axis and flow is going to be on the y-axis. And we do this spirometry to see if there's obstruction. And then you want to give bronchodilators to see if the bronchodilators have any effect on the volumes or the flow. And then masculine sounds testing, we won't talk about it if we don't have time. And less often we do, what is the maximum inspiratory pressure these patients can generate? What is the maximum expiratory pressure these patients can generate? So often that we do this to assess neuromuscular strength, neuromuscular weakness. So MIP, which is your most dominant inspiratory muscle? Diaphragm. So if patients who have diaphragmatic paralysis, who we consider they may have diaphragmatic weakness, we do that MIP. This is an example of a PFT. So look at so many acronyms, right? Can everybody see that? So many acronyms there. So these are the important things that we're going to focus on. FVC, FEV1. FEV1 or FVC ratio. What is the ratio? What is FEF 25-75? We call them mid. Because FEF is forced expiratory flow between 25% and 75% exhalation. Basically, middle of exhalation. And we also look at peak expiratory flow. And we want to talk about MVV, maximum volume ventilation, total lung capacity, residual volume, and then gas transfer. So DLCO stands for diffusion capacity in the lung for carbon monoxide. So some textbooks actually across the Atlantic they write it CLCO, but in America let's stick with DLCO. So that's why. So this is the glossary, and everybody's familiar with these terms, right? Good. So FVC, FEV1. Any questions about these? Excellent, because we're going to be using this through and through in the next 30 minutes. Excellent. And are we familiar with the volumes and capacities? So what is the difference between a volume and a capacity? Volumes are single compartments. As soon as you start putting two or more together, it becomes a capacity. For example, this alone is tidal volume. But if you add the inspiratory capacity to it, inspiratory reserve volume to it, it becomes inspiratory capacity. If you add inspiratory capacity, tidal volume, and expiratory reserve volume together, that becomes the vital capacity. All of the volumes together, it becomes the total lung capacity. What is the volume of air? Even after complete exhalation, you cannot get it out. What is that called? Residual volume. Very good. Residual volume. And the residual volume, so residual volume along with the expiratory reserve volume. So what is the expiratory reserve volume? This is, you're doing normal breathing. You do a normal exhalation, and then you go over and beyond and exhale everything you can. So between the tidal volume and whatever you can exhale, so that's called the expiratory reserve volume, so the ERV. So you add the ERV to the residual volume, that becomes FRC, functional residual capacity. Functional residual capacity is something really cool, because FRC is going to participate in the gas exchange, whether you're inhaling or exhaling. Listen. Isn't that cool? So the FRC, people with low FRCs, if you don't give them, say they require supplemental oxygen. People with low FRC, if you take them off oxygen, their saturation will drop like a rock immediately. So the people who have good FRC, normal people, say they require supplemental oxygen, you have them on non-rebreather or 4 liters, 12 liters oxygen. You take them off the oxygen because they still have FRC, they're still having some gas exchange. It might take them a minute, couple of minutes, sometimes 4 or 5 minutes before they reach that. So can you think of a couple of conditions where the FRC is low? So this is something pushing the residual volume out. Pregnancy. So who said pregnancy? Correct, absolutely correct. So pregnancy, so what else can look like pregnancy? Obesity. Bronchial obesity aside, it's good. So those are a few things that I keep in mind when I'm seeing a patient in the ICU. We are trying to intubate them. You want to do for these three situations I talked about, we want to do rapid sequencing, right? So this is when I want my best anesthetist, the endocrinologist, and the director of with their hands while I'm giving them the medication. Good, excellent. Any questions about these volumes and capacities? Good, because if we have an understanding of this, then we can move forward. Excellent, excellent. So this is spirometry. This is how spirometry is done. So you guys already have an idea, so I'm going to cut this in. I do have a video. I don't think you can watch the video. It's done right. Yes, no? Good. I'll try to send this to Dr. Reed so you can send it to you guys. All right? Good, good. Excellent. So this is, so spirometry will measure some of the volumes, especially if we can measure up to force vital capacity, but we cannot measure the residual volume using spirometry. So to measure the residual volume, we call them the body parts, but I don't like to call it the body parts. So this is the body plethysmograph. So this is previously used to be made of opaque material. So the patients used to be feeling more claustrophobic. Now it is made of fiberglass. Made of fiberglass, patients can look all around. So even claustrophobic patients can do this. So they go in, we shut the door, and then they're breathing in and out. They're doing a panting maneuver. And using the variation in the pressure and the volume, there's a huge calculation that the computer will do. This is going to measure the FRC. So this will measure the FRC, functional residual capacity. So this measures the FRC, and then using the FRC, we're going to calculate the total capacity. Good. So now how is gas transfer measured? So we get the first they inhale known amount of carbon monoxide, and then they're going to hold their breath for about 10 seconds, and then they exhale. And then whatever the patient exhales is collected and measured. So using this, so what goes in, what comes out, the difference is what the patient absorbs. Using that, we determine what the person's carbon monoxide transfer factor is. Right? Why do we use carbon monoxide? Why don't we use carbon dioxide or oxygen? Because there is a significant amount of oxygen and carbon dioxide already present in our body, so it's going to mess up our calculation, right? And carbon monoxide is something that is safe, that is easy to store. You want to explore on us. And do we have carbon monoxide in our body? We do, a minuscule amount. People who smoke, they might have more carbon monoxide, right? So that's why we use carbon monoxide. Oh, more importantly, if you look at fluid solubility characteristics, compared to oxygen, carbon dioxide is 20 to 25 times more soluble. Carbon monoxide is 200 times more soluble. So it's probably the ideal gas that we can use to measure gas transfer. Good. Questions on that? Good. Good. So this is how the spirometry will calculate. We can figure out what the inspiratory capacity is, and then your plethysmogram will tell you what the FRC is, and then add both, you're going to get the total capacity. Good. All right. So as I said, PFTs, there are only 3 questions. There are only 5 in these patterns. Simple. Good. So what are the 3 questions? We already talked about this. Is there obstruction? You got it. That's it. Only 3 questions. What are the 5 patterns? Normal pattern, obstructive pattern, restrictive pattern, pulmonary vascular disease pattern, neuromuscular disease. I told you guys about the mixed pattern, but I guess we'll challenge the fellows with the mixed pattern. That can get confusing. So normal, obstructive, restrictive, pulmonary vascular disease pattern, neuromuscular disease pattern. Of all this, the neuromuscular disease pattern challenges even some of my faculty, so we probably want to skip that today. But if you guys are interested, we can definitely talk about it after class. So what is normal? Normal, how do we determine what is normal? We study 1,000 who we think as normal people are, right? And most of them, if you plot all the data, 99 or 100 times, it's going to be a bell-shaped distribution, right? So using this, the outlier 2.5 on this side, 2.5% on this side, we exclude, and the middle we going to call normal, right? So if you take that as normal, anything that is 80 to 120% of predicted, how do we know what is predicted? Once again, we study 1,000 people and have these normograms ready to go, and these are now plugged into computers and so forth. So that's normal, right? 80 to 120% predicted. If it's less than 80, we call it low or decrease. If it's more than 120, we call it increase, right? Obstructive is, we're going to use the FEV1 over FVC ratio. We're going to do FEV1. So what is FEV1? forced expiratory volume in 1 second. How much volume this person can exhale in 1 second? Divided by what is the vital capacity space. If what the FEV1 is 1 liter, vital capacity is 2 liters, is 1 divided by 2. That's a half. So the FEV1 FVC ratio is 0.5. It's less than 0.7, so that becomes obstruction. Simple. What is restrictive? Restrictive is FVC and total lung capacity both are reduced, and they both are less than 80%. Less than 80%. Pulmonary vascular disease. So there's nothing wrong with the airways, nothing wrong with the lung parenchyma. So spirometry is normal, lung volumes are normal. Only the DLC was reduced because we talked about alveolar capillary membrane. On the capillary side, there is no hemoglobin to pick up the carbon monoxide, right? So that's going to happen in pulmonary vascular disease. You can see this in pulmonary arterial hypertension, or you can see this in patients with chronic thromboembolic disease. Can anyone tell me another condition that is not a PE, that is not a thromboembolic disease, where the DLCO can be low? Actually, heart failure is pulmonary vascular congestion, right? There's actually more hemoglobin. In fact, early heart failure is one of the conditions where DLCO is increased.
Sickle cell?
Sickle cell. What is it?
Just anemia.
Just anemia, exactly. So anemia. So sometimes we skip anemia. So anemia is one of the common conditions that can cause a reduction in DLCO. That's why when you do a DLCO, you always have to do a hemoglobin correction for the DLCO. Good. And neuromuscular disease. Neuromuscular disease basically, you put a chart, all volumes will be reduced. Only the residual volume will be high. Can anybody tell me why? So very simple. They don't have enough strength to blow everything out. So they have some residual volume that is still left behind. So all volumes will be low, but residual volume will be high. Good. So this is normal. We already talked about this. DLCO less than 80%, because it's a more variable test. It's a slightly more difficult test to do for patients. So till about 65–70%, some of us still call it normal. So we always take that into the context of what the patient's problem is. In general, in other words, 80 to 120 is normal, less than 80 is decreased, more than 120 is increased. So here, for the FE1 FE2 ratio for the purpose of this class and your exams, we're gonna come to say FE1 or FEC ratio less than 0.7 is obstruction. Okay, good. Let's interpret this. This is easy. 60-year-old smoker is now got a cough, and you did spirometry in your office. His FEV1 is 2 liters. Sorry, flip that. Sorry, FEV1 is 1 liter. FVC is 2 liters. I made this slide last night. Sorry. FEV1 or FVC ratio is 0.5. DLCO is 40%. What is it? Obstructive, right? Obstructive. Because the first thing you do in a PFT problem is do the FEV1 or FVC ratio. If it's less than 0.7, it's obstruction. If it's not less than 0.7, it is not obstruction. That's it. Good. So this is obstruction. What about this one? Did I do this one right? Yeah. So FEV1 is 2 liters. That's 55% pretty good. That's low. Decreased. FVC is 2.4 liters. That's 60% pretty good. That is also decreased. When you do the ratio is 0.83. So this tells you there is no obstruction. Total lung capacity is 60% pretty good. So lung capacity is to come down. Vital capacity is come down. DLCO is also reduced 40%. What is this? Restrictive. So this patient has restrictive disease. Lo and behold, the DLCO gas transfer is also affected. Gas transfer. So we'll see how we put that in context. Good. So disease patterns. Obstruction. Obstruction can be improved with bronchodilators, or obstruction can be fixed obstruction, relatively fixed obstruction, right? And fixed obstruction can be associated with a relatively normal DLCO, or a fixed obstruction can be associated with a significantly reduced DLCO. And there's another scenario where you can have restriction with a normal DLCO. We'll talk about why and when that happens. And then restriction with reduced DLCO. just like the one that the example that we saw. Patient had FVC was low, DLC was low, DLC was also low at this one. And the last thing is everything is normal with the reduced DLC. So these are the patterns. So obstruction that is improved with bronchodilators is asthma, right? Asthma is reversible bronchospasm, at least in the early stages. Obstruction that is fixed, COPD, very good. So I don't want you guys to think all patients with COPD obstruction is fixed. It is actually variable, but it's not as reversible as asthma. And also, most asthmatics in the early stages, they will completely reverse. For example, if you do FEV1 and FVC, they may be 60% predicted. 2 puffs of bronchodilators, wait 7 minutes, repeat spirometry. The 60% predicted might become 90% predicted. So that's completely reversible. So that's classic asthma. But COPD may reverse, but it's not going to reverse back to normal. So there will still be some obstruction to form. So obstruction that is fixed is COPD. Among the COPD, we talk about chronic bronchitis versus emphysema. Chronic bronchitis is where your DLCO is going to be relatively normal, and emphysema is where your DLCO is going to be definitely reduced. Why is that? Head tracking. So COPD mainly is an airway disease, right? What is the pathophysiology behind emphysema? What actually is happening?
The alveolus.
The alveolus?
Yeah.
There's alveolar destruction. So alveolar being collapsed, right? So one of the things that determines DLCO is, so what are the determinants of DLCO? How much alveoli they have, right? The surface area. And what is the thickness of the alveolar capillary membrane? So thicker alveolar capillary membrane, DLCO is going to go down. Not enough alveoli, the DLCO is going to go down. So that's why emphysema, DLCO is low. So restriction with normal DLCO. When you do spirometry and lung volumes, they are low, but the gas transfer seems okay. The gas transfer is normal, that means the parenchyma is normal. So this is a chest wall disease, right? Chest wall disease could be fibroscoliosis, could be somebody with systemic sclerosis, a scleroderma with leather-like skin that binds them down. And in fact, if you put a chest binder on a normal person, do PFTs, this is what you're going to see. So it's a chest wall problem. Restriction with normal DLCO. Restriction with reduced DLCO, there's pulmonary fibrosis, so all volumes are down, and the alveolar capillary membrane is big, so the DLCO is also low. So everything is normal with reduced DLCO. What do we call this? Pulmonary vascular disease pattern. Airways are fine, lung parenchyma is fine. The only problem is the blood flow. It's either chronic thromboembolic disease or pulmonary arterial hypertension. Excellent. So remember anemia. One of you already pointed out. We got to keep anemia. Excellent. So what are the causes of reduced DLCO? I'm going to shoot through this because we've already talked about it a little bit. Anemia, because there's not enough hemoglobin across the alveolar capillary membrane to pick up carbon monoxide. Pulmonary arterial hypertension. There is some thickness on the endothelial side. However, one of the main reasons, if they ask you in test, why DLCO is reducing pulmonary arterial hypertension is decreased capillary blood volume. Decreased capillary blood volume. Chronic thromboembolic disease, obviously, as we talked about. Early emphysema, history of smoking, there cannot be enough airflow obstruction to show COPD, but this patient is started to lose alveoli, so the DLCO can be low. Interstitial lung disease as well, because of the thickness of the alveolar capillary membrane, DLCO as well. You may not have to know this, but there are very few conditions that cause increase in DLCO. Polycythemia, just like how anemia, patients with anemia can have reduced DLCO, patients with polycythemia can have increased DLCO because now you have more hemoglobin to pick up carbon monoxide. Early congestive heart failure, we just talked about, there's pulmonary vascular congestion. Of course, the patient is having early congestive heart failure, decompensated. We're not going to be doing PFTs, but these are physiological studies done about what happens in triathlon. Pulmonary alveolar hemorrhage, have you guys heard about this? So there is bleeding into the lungs. So there are some rheumatologic conditions that can cause pulmonary alveolar hemorrhage. Can you think of one rheumatologic condition where pulmonary alveolar hemorrhage is often talked about? Systemic lupus erythematosus. So lupus erythematosus is one of the conditions that come to mind. Patients with Wegener's granulomatosis, right? Or some other rheumatic condition. Vasculitis, very good, thank you. So microscopic polyangiitis, whatever the cause is. So those patients can have pulmonary hemorrhage. So here, if you do a gas transfer test, there is free hemoglobin that is in the alveoli. So it's going to pick up the carbon monoxide. It's going to make it look like the gas transfer is higher than normal, but the gas is not going anywhere, right? It's all in the alveoli. Good. Obesity. So obesity, we're still debating why, but I think these patients have increased capillary blood volume. Increased capillary blood volume. So that's what is causing increased DLC on patients with obesity. Good. Questions? Finally, we got to where what we want to talk about. So how do you PFTs? So first question is, who's the patient, right? What is the indication? Why are the PFTs done? You want to know these. Is the effort of the patient adequate? Somebody is doing the core test, right? So is the effort adequate? Is this test interpretable, right? If the test is not done right, there's no point in interpreting the test. Is there obstruction? If obstruction is present, is it reversible or is there improvement with bronchodilator? Next thing you want. And then next question is there restriction? Is there impairment in gas transfer? That's it. Can we go home? Okay. So this is a snapshot of PFTs that we see. So here we see you'll have some more information about the patient's name above. And this is a male patient. He's an African American. He's 56 years of age, 66 height. He weighs 201 pounds. And why was this done? He has dyspnea and exertion, EOE, and he has a history of asbestos exposure. And this is the patient's physician. And this is our technician, Maria Shah. She's awesome. She's one of the best. So do you guys know where's the best PFT lab in the Memphis Metro? Say VA Medical Center. I'm not kidding. So this is generated from there. Memphis does a great job as well. So, and then here on top we have spirometry, and under that we have lung volumes, and then we have diffusion. This is what we call as the flow volume group. So on the x-axis we have volume, on the y-axis we have flow. So here the patient is doing tidal breathing. This is inhalation, exhalation, inhalation, exhalation. And then the technician says, "Oh, take a deep breath." So after they had a normal exhalation, they take a deep breath. And so this would be a forced inhalation. Forced inhalation, after that, he says, "Blast everything out." So it's a forced exhalation with a peak flow that just, look at that, smoke that cover here, smoke the number 8 here. And then you continues to exhale. And then as the lung empties out, the flow starts to drop, right? Because there's not much air to flow out, and it drops and it touches the patient. So this is a flow volume loop. Flow volume loop. So for adequacy of the test, we also look at the flow volume loop. Is it a nice, robust inhalation loop? Is it a nice immediate peak? And there's no stuttering. If the patient has a lot of redundant tissue, it might stutter. Some patients start hiccuping or coughing. You'll see stuttering here. Some patients sleep apnea sometimes will show redundant tissue kind of vibrating here. You don't see any of that. It's a nice, robust, clean flow volume, right? And here we also look at this curve. This is volume on the y-axis, time on the x-axis. This also tells you the patient exhaled swift and fast, and he kept on exhaling. And this is one of the important notes that we look at to see, is this test interpretable? So exhalation time should be at least 6 seconds. If the exhalation time is less than 6 seconds, that becomes a leaky test. That means the patient did not exhale enough. So we don't know what to make of the volumes of the patient has exhaled. And this is the MVD maneuver, maximum volume ventilation. Notice that this is only done for 10 seconds. If somebody breathes fast in and out for a full minute, what's going to happen to the person? They're going to pass out. The CO2 is going to go to 20, and the blood is going to become alkalotic, and some patients can even have seizure, right? So what we do is we do this for 10 seconds, and then we multiply by 6 to extrapolate what they would have done for a full minute. Excellent. Questions here? And this is the DLC maneuver where they inhale and held their breath for 10 seconds and exhale. So everything okay. Good. Questions here? Excellent. So is this interpretable? So go back here. We also want to look at the note from the technician, that's important. And then we already talked about exhalation time should be at least 6 seconds. And then good looking flow volume, as we talked about. So look at what Maria Shah wrote here. Good patient effort. And she also usually writes what the most recent hemoglobin is. So in case we need to correct the hemoglobin, correct the DOC of the hemoglobin of the patient. Good. So that's that. So 5 ways to detect obstruction. We only talked about 1 way to detect obstruction so far, right? What was that? How do we detect obstruction? Ratio. Good. Good. Less than 0.7, that is obstruction. So there are actually 10 ways, but I'm going to tell you only 5. The next time you don't tell you the other 5. So we call it scooping of the flow volume loop. So we see the nice relative flow of flow volume loop, right? So we're going to, if we see scooping, if the patient has obstruction, this is going to scoop over here. Continued ascendancy of volume time curve. So the patient does not have obstruction, air comes out and it comes off, right? And it plateaus quickly. If the patient has airflow obstruction, this is going to keep coming out and it does not plateau. It continues to keep climbing. And then this is the peak flow, right? This peak flow won't be so high, it will be blunted. The peak flow can be blunted. And then we talk about FeV1 ratio. Number 5, mid, we call this mid flow rate. So if all of this is expiratory flow, this is 25%, and this is 25% is 70%. So we call that mid flow rate. So mid flow rate, we generally consider that as indication of small airway obstruction. But we don't need to go there. So here's the scooping of the flow volume that I talked about. So the more the scoop, the severe the obstruction as well. And here's the continued ascendancy of the volume time of the stop. Good. Good. So restriction, we already talked about FVC less than 80%. Predicate is suggestive of restriction. That's why you need to do long volumes to confirm restriction. Good, good. So reference equation, this may be tested on it, I'm not sure. So reference equations of PFTs are based on age, older people are, lower some of the volumes, right? So lower, and sex. Males in general are about 8, they have 8 to 12% more volumes because they're taller and they're bigger. And the taller the individual, higher the lung volumes as well. Male versus female, we talked about. Caucasians versus African Americans. For the same height, Caucasians have higher lung volumes because, any idea why? Any anthropometry students here? So the African Americans, they have longer extremities. So even though they may be the same height, their thoracic height is less than the Caucasians. So Caucasians in general have 10 to 12% more lung volumes compared to African Americans. Asians is the same way. Asians are in general smaller. So here's a normal flow volume group. We already went through this. Here's the obstruction showing this scoop, right? So that's really normal. And here's a patient who has severe obstruction. Look how far away this is scooped. And this is a patient with chronic bronchitis. This is a patient with emphysema. In general, patients with emphysema, they lose weight. They are pretty thin individuals. And here's a classic COPD VA patient. You can see, I appreciate the empathy of the nurse that is showing this patient. That's very important. Good. Okay. Here's emphysema. So here's a normal, relatively normal chest X-ray, patient with normal lungs. Here's restrictive disease. You can see all the scarring from all the fibrosis, right? And here's obstructive disease. So look at the difference in the volume between the obstruction, normal, and restriction. So if I put a similar sized rectangle on these, this rectangle is bigger. This rectangle is, the lungs are much bigger than the rectangle, right? So obstructive disease traps air and hyperinflates the lungs. Restrictive disease, it's collagen. So collagen starts to scar down, like scars contract, right? So the patients start to lose lung volumes. So that's what happens. So these are normal lungs, and this is a patient with pulmonary fibrosis. So one time I was in the operating room when they were trying to do a lung biopsy. Normal lungs would feel like very soft sponges. I try to feel it, it just crumbles on my touch. Whereas a fibrotic lung, it was like steel. So that's why we talk about umbilical capital membranes are what half a micron thick, right? So all I have to do is drop my intrapleural pressure just a tad, air fluid freely flows in. But for patients with pulmonary fibrosis, their inspiratory water breathing is so high, they have to work hard to get that air in. So that's one of the costs of dyspnea in these patients. So restriction. Notice restriction that all volumes are down, but it looks like a normal but miniaturized curve when you look at the flow volume. So that's how that looks. Already talked about this. So restriction. We already alluded to this, but I want to make this point again. When you have restricted physiology, meaning FBC is low, total lung capacity is also low, you're going to differentiate pulmonary restriction versus extrapulmonary restriction using the DLCO. So the DLCO is low. The problem is in the lung parenchyma itself. It is starting down. If the DLCO is normal, when a patient has restricted physiology, the lung is normal. The problem is going to be chest wall. It can be chest wall, it can be pleural fibrosis, bilateral pleural fibrosis. For example, if the patient has bilateral pleural effusion, that's what he or she can have. Good. I want to read a few PFTs. We have 8 minutes to do that. So I need a volunteer. Who's the bravest of you all? Nobody. Let's somebody from the back. Come on. Be a volunteer. Come on. Yeah.
All right, let's do it.
Let's do it.
Okay, let's do it.
Let's do it. So, what do we say? Who's the patient, right? So this is a Caucasian.
6'9" Caucasian. He's 71 inches tall, 122 small. His FBC.
The third thing we asked was, the second thing, why is it done? What is the indication was not given here? What is the third thing we want to talk about? Is this interpretable? So where are we going to look? We want to look at the flow volume time curve. So how does the volume time curve look? Less than 6 seconds. So this is let's read what the PFT technician's comments are. Good patient effort, but fair performance due to very short breath. SOB, that's what we call it. Yeah. Patient attempted. So when I write my chart, I write SHOB to make sure that I'm not calling it SOB. SOB, right? So patient attempted. So this was. She even alluded to us that this is patient effort was not great. I completely agree with you. The volume time curve is so low. I'm not going to interpret this much. Good, you're done. Awesome. Let's have another volunteer read it. Somebody from the back. No, Lauren, you did not. Yeah. I want somebody else. Somebody from the back. Come on, guys. I told you, take intellectual risk. Yes, go for it.
So, 35-year-old African American male, 70 inches tall, 209 pounds. And under 2 months.
Yes, but that we'll excuse them for that. And then you want to see if this is interpretable. What do you think about this volume time?
So 8 seconds.
It's 8 seconds. It's actually 8 seconds, and then it keeps going. So this is good. And let's see what the text said about this. Good patient effort. Patient given 2 cups of program. That is a neuro post test, and she even gave us the chemo. Good, excellent. Now let's start from here.
Your FBC is at 72. EB1 is 57. Your NEB1 is
Ratio is 65. Good. 35% predicted. That is also low. Good. MBB is also 50% predicted. That's also low. DLCO is 83% predicted. So what do you think this is? Is it obstructive, restrictive? Obstructive, very good. So the FEV on FEV ratio is 57%. So it should be, if it's less than 0.7, this is 0.57, obstruction, very good. And gas transfer is normal, right? Let's see what happens with bronchodilators.
So it increases, your LC decreasing. So it would be asthma, correct?
Very good, very good. So this, yes, so it's, let's say it's likely to be asthma. So the FVC improved by 10%, but the FEV1 improved by 25%. So here's when you're looking for bronchodilator reversibility, I should have made this as a slide. You're looking for two things in two things. You're looking at your improvement could be in FEV1 or it could be in FVC. So what are we looking for? 12% and 200 cc's. So either one of them should go up by 12% and 200 cc's. So both should be present. So here, in our case, FVC increased by 10%, not enough. FEV1 went up by 25%, and what is the increase in the volume there? So it went from 2,710 cc's to 3,400 cc's. So it went up by 700 cc's, right? So that checks the box for improvement in bronchodilator. So you said this is likely to be asthma, absolutely correct. So the way I'll interpret this is obstructive ventilator defect that responds to bronchodilators, right? Likely to be asthma. And most patients with asthma will have a normal DLCO. Well done. One more. So this is obstruction that is improved with bronchodilator, normal gas down. Want to do one more? Who wants to read this? Come on. Dr. Reed will give you candy.
I have a really nice pen.
I'll go.
Okay.
Go for it.
So 41-year-old black male coming in for narcotics. So SBC.
Let's look here first.
So it is interpretable. It's great.
Good. And you and your text said good patient appointment. Excellent. Now we can go here. Good.
SBC is 51%, so that's slow. FEV1 5%, so that's slow. The ratio is 89%, which is normal.
Good.
So that's restricted.
Good. So that's suggestive of restriction. Now you're going to look at
Suggested of restriction.
and you're going to look at the volumes to see if you confirm restriction. Good. Let's look at the volumes. PLC.
49, so that's low.
So you confirm restriction. Very good. And then
And then the LCO is low, which would indicate intrapulmonary.
round of applause for that. Come on. Excellent, excellent. So that's restrictive ventilator defect with reduced gas transfer. 1 minute to spare. We're going to wait for Dr. Ferreira to come. Thank you.
Everybody stand. And then just please shake, move your shoulders. And if you can stretch your right hand, please stretch your right hand.